Yeah, I'm going to. Well, I can get started with a few announcements and introduce our speaker for today as other people get snack. If you haven't had a chance to get a snack, so welcome everybody. I'm Jennifer Schrack, for those of you who don't know, Director of COA. Some announcements. So we have one more seminar this year after today, and that will be Dr. Jennifer Deal, professor in epidemiology, and her talk will be titled "Where Do We Go From Here? Updates from Cochlear Center for Hearing." And here is the yeah. And then looking ahead to next fall, we will start in October. We don't start September because it's getting back into the swing of things, but we will start October 5th. Mr. Dickerson, associate professor of epidemiology. I don't have a title for her yet. Sure. So today I am very happy that we have Dr. Daniel Polsky here to talk with us. He's a Bloomberg Distinguished Professor of Health Economics at Colorado University. And I don't know if everybody knows how the Bloomberg Distinguished Professorships work, but you have to have an appointment in two places. So he's here in Health Policy and Management and also at the Carey. He also holds secondary appointments in the School of Medicine and in the School of Nursing. Director of the Hopkins Business of Health Initiative, which unites more than 150 scholars across JHU and explores the role of and incentives in advancing health and health equity in high-value healthcare systems. Co-director of the HEAD Center, the Health Alzheimer's Disease and Service Centers, with Dr. Jennifer Wolf and also with Dr. Cynthia Roy. Through 2019, he was the Robert D. Eilers Professor at the Wharton School at the University of Pennsylvania. And he was also the executive director of the Leonard Davis Institute. He stole him away and in 2019. He's a national leader in the field of health policy and economics, and he's dedicated his career to understanding how healthcare is organized, managed, financed, and delivered, especially for lower income. Member of the National Academy of Medicine, and he was the senior economist on health issues at the President's Council of Economic Advisors, and he served on the Congressional Budget Office's panel of health advisors. He has his master's degree from the University of Michigan, go Blue, and he also has in economics from the University of Michigan. So with that, I will welcome Dr. Polsky.
It's great to be here. I see so many faces and faces I've seen on Zoom and others that have been on my grants. And so like so many connections here. It's really wonderful to be here. So, thinking about what I talk about, and I'm thinking a lot about Medicare Advantage. I'm an economist. Probably. So much to get into the kind of things that we're working on, but I'm just going to go for it. So I think about that and have fun with it, so that I'd share some of the fun. But also, many of you are familiar with the HEAD Center. Probably less familiar with the Hopkins Business of Health Initiative. So I thought I'd also share a little bit about what we do there. Other people want to play in that playground. So let's cover the next 50 minutes or so. So let's get started. So what is Medicare Advantage? Let's start there. Does that sound good?
Yeah.
Okay. So Medicare is the insurance program predominantly for Americans over 65 years of age. About 40 million people in the Medicare program, or half of them have, in the past 20 years, the way that Medicare works has changed dramatically. It used to be what we call now traditional Medicare. Was the only Medicare, so then it's called traditional Medicare. It's called Medicare. Basically, you get care, you bill the Center for Medicare Medicaid Services, and then you get money. It was a place that just sent checks to providers. How Medicare worked for decades, And so starting in the 90s with, Medicare, with the managed care, and then it really started picking up in 2006 when they changed some of the incentives. Well, they said, why don't we try to, create in more innovative ways to bring in managed care and to have care coordination with the patients, because if we're just paying checks, there's so much efficiency we can derive from the system, because that's just inefficient. If we have like care coordinators and ways to just have someone in charge of how care pathways happen, we can deliver care more effectively, save the taxpayers money. So they created this program. It was called Medicare Plus Choice at the time, and then changed to Medicare Advantage now 20 years ago. This is how it works. You're in Medicare, you have the choice. You probably have maybe try to help your parents navigate this grandparents. And the decision is, should I, you just default, you get signed up in Medicare, maybe you go on Medicare Advantage, like on it's called, but you can choose among like dozens of plans. You can get like lower premiums. You get like your drug benefit attached to your Medicare, your Part A and Part B benefit. You don't have to pay like as high premiums for your physician care. You have this out-of-pocket max. In traditional Medicare, there's no out-of-pocket max. So like if you in hospital for like 100 days, like you're going to go bankrupt or something like that, unless you have like a gap or some type of supplemental insurance coverage for that. You can get some dental care, vision care, things that Medicare doesn't cover. Pretty good deal. To get that insurance, you buy a plan from a private insurer, like a United Healthcare, Humana, Aetna. Those are the big players in Medicare Advantage. Buy your plan, you sign up for the plan through them. It's not going to cost you, it's probably cost you less than if you sign up for traditional. And the way that it works from the insurance company's perspective is they tell CMS, like, listen, we have this like big pool of members. So you pay me a per member per month fee for my like million members or whatever you get. More than the plan has, but I don't know what it is, like, $1,000 a month. And that's how the insurance company makes money. But then they got to pay the bills. They pay the bills, and it's the way that they make money is they try not to pay, they want their expenditures to be lower because they've capitated and how much money comes in. And if the expenditure is lower, then they make margin. So you can imagine the types of incentives that this creates. It's very different than traditional Medicare. You pay a bill, you send your bill to Medicare and they pay the bill. Here, the insurance company doesn't really want to pay all the bills. So what do? They do things like prior authorization to make sure that the things that they're paying for, meet some evidence standard. They have to manage care for their providers. So they have contracts with the providers. So like this hospital system, these physicians are in my network on the plan, and these are not. And so when I focus on managed care, I can focus on the providers that sit within my plan. So I can like derive some efficiencies, build some care coordination, build some, IT systems, help them manage their care, make their decisions. And those are the kind of ways insurance companies have push value to their beneficiaries to sign up for their plan that would never exist in traditional Medicare. Sounds brilliant, doesn't it? Like it's going to work perfectly. Well, it hasn't really worked perfectly. I don't know how much you guys read the news and things like that. But that's the basic idea of Medicare Advantage. Right now, Medicare Advantage, more people sign up for Medicare Advantage than traditional Medicare. It's like 55% of people in Medicare have these private plans. 20 years ago, that was like 16%. Dramatic transformation in how older Americans are being cared for. Because it's not just coverage and who pays for the care. It actually transforms the delivery of healthcare. Now there's an important relationship between the insurance company and the delivery systems that deliver that care and the beneficiaries of their health. Coordinated, connected system, for better or for worse. is Medicare Advantage before. But let's talk a little bit about the implications of this system for policy. So this is kind of the outline of my talk. The big question from the policy side is the cost of this model worth it for the taxpayers? The deal was when it was started, this will save money. It's going to be 95 cents on the dollar. The reports that come out from MedPAC, the commission that advises Medicare on how the program's going and changes that policymakers should make, say it's now about $1.20 for someone who goes through the Medicare Advantage program versus someone who went through the traditional Medicare program. That's created a big conversation about what are we doing, paying all these big insurance companies all this money. But actually, the people in Medicare Advantage, they're relatively happy until something goes wrong. They actually get they get more benefits. They can get dental benefits, vision benefits, supplemental benefits, a lot of things and this, big protection from out-of-pocket maximums never exists in the traditional Medicare program. That's worth it. I'm going to go too deep into some of the work we're doing there, but it's kind of an overarching question. I'm going to talk about sets of papers we have in these 4 different areas. So you're not going to get all my geeky methods. I'm just going to show you a bunch of results. So you're really disappointed. Hopefully we'll have some fun. So they're really perverse incentives of the program. Risk adjustment coding. If anyone, this is it's every day. It's in my world. I don't know. You guys have no idea what I'm talking about, but risk adjustment. It's the most exciting thing. The intensity of prior authorization that exists in Medicare Advantage. Also managed care, right? They have these restricted provider networks. It's easier to manage care when you kind of limited number of providers you're talking to if you're an insurer. Has advantages and disadvantages. Maybe they select the best high value providers. And so, it's curated for you instead of choosing at random which provider to go to. But you have to find providers to provider network directories. Market dynamics that have really changed how all of healthcare is delivered, consolidation, vertical integration. We'll get into that a little bit. And if there's time, we'll talk about patients and implications for patients. So we want to get to patients. It's the most important stuff. So let's start with addressing perverse incentives of the program. That's where economists like to spend their time. So maybe even my co-star presented this paper to you, John. We did this paper on visits. Care pays for 0 out-of-pocket costs. You can get an annual wellness visit, which can really be a nice way to trigger preventive care for people with cognitive issues. It's a place where they maybe get some diagnosed. So if we can get the relatively healthy elderly into a visit annually, it's a tremendous incentive to work on the healthy part of the care that gets provided in the healthcare delivery system. So our first paper here in this area looked at percentage points more likely to get one of these annual wellness visits, Medicare Advantage, than if you were just doing it on your own. So it seems that's a really good thing. So then we look more deeply at the data, and it turns out that that dotted line that comes across is the averages in traditional Medicare. The only reason Medicare Advantage is higher and traditional Medicare is pretty much what United Healthcare Group does. So what United Healthcare Group does, they want to get really healthy people into their program that they can get the per member per month fee, people who would never use healthcare. And what they do is they got a lot of people working there thinking about how to take advantage of weird things in the system. I should have mentioned this before. One important feature of the program is per member per month fee is they want to guard against these insurance companies not taking care of sick people. Of course, the sicker you are, the more likely you are to use healthcare. So if your expenses are going to be higher than the money coming in, you might not want those people. So they have this really elaborate program of risk adjustment. You can get higher payments for your diabetes, your people with end-stage renal disease, whatever these kind of conditions are that generate the highest expenditure. We can predict those expenditures ex ante, and you get this per member per month fee adjusted for the risk of your patient population. What do you think Medicare Advantage, or what do you think they're doing at United Healthcare? Go to your house and make the people who would never show up for anything because they're basically healthy, bring like some type of staffer there. Let me check your blood pressure. Oh, you have high blood pressure. Check. Let me check your glucose. Oh, you have some issues there. I'm gonna check, now you have diabetes. And so they basically go to people's homes for people who don't use much healthcare, and they risk code them with all these risks. So we found in this paper that the reason they have higher annual wellness visits is not because they're really worried about prevention, but they're going into the homes trying to get higher payments so that their stockholders can be happy. That's where we are with this research. I want to do a little more work because maybe they find things that they actually follow up on and it turns out to be a good thing in the end. But we have some more work to do there. But it just seems that the United Health Group kind of stands alone, at least in this period of 2019, as the insurance company that was most likely to play games with some of these perverse incentives that sits in the program.
Good question. Is it higher payments, or they want to get rid of more expensive patients who might not be using services?
So they show up for that annual wellness visit. They're showing up in the homes of the people who have already signed up for their health plan.
Oh.
So they're just trying to get more money from CMS.
Okay.
As per member per month.
Gotcha.
We'll talk a little bit later about are there ways, and we'll talk about that here. Are there ways that maybe once you have people in your program, what would be a way you might be able to get rid of the people who are costing you the most? One thing we're going to study now is we just sent a grant into the National Cancer Institute. One thing that happens is that Cancer Center here at Hopkins. So the most complex, very precise cancers that are really hard to do risk adjustment for, like the rare, expensive cancers, never make money off of those patients. If you're the plan in managed care. Maybe you should leave out fancy cancer centers. That's the way you can maybe dump patients that would be unprofitable. Make sense? So anyway, that's a project that we have coming up. So there are lots of ways that we might want to think about. So then the question then becomes, one way that managed care or Medicare Advantage is different than traditional Medicare is Medicare Advantage as provider networks. List of providers. How many people have done it with their health plan? You go on, find a doctor, and you type in the zip code, and you see this big long list of providers. One problem is those lists can be horribly inaccurate. But also the reason, there might be good things about these networks too. These plans want to have good doctors in there that are going to deliver efficient care because they're trying to, make sure their patients stay healthy and don't drive up the bills of these health plans. We're going to look at some of the trade-offs of managed care. They restrict the number of doctors in the community. On average, about 40% of the physicians in the community are in a typical network. Some it's smaller, some it's a little bit larger. And the way that they send patients to these doctors is you have lower copays, it's easier to get care if you go to a provider that's covered within the network. So what we wanted to look at is, what are these plans thinking about when they pick the primary care providers that sit in their networks versus those that they leave out? Who are they steering their patients to through lower copays and things like that? They select the ones that the primary care docs have better managed care and are more likely to avoid hospital stays or avoidable conditions like, exacerbation of. A couple papers in this area, just look at the raw data. A higher rate of, this was a fact before we started studying it, that you see fewer hospitalizations for avoidable hospital stays for people with chronic conditions in MA than traditional Medicare, 3 percentage points lower. Is it explained by the doctors, primary care doctors that are in network versus those that they exclude? And the bottom line is, we did all this work, maybe I'm going to skip all the data stuff, but we used all the claims data, linked it to like network data, identified, from the claims data, ambulatory sensitive conditions, blah, blah, blah. I'm not going to get too many results to show you. I'm just too excited about. So feel free to like interrupt with questions if I'm going too fast. And also if I'm going too slow, you can say like. So here's like the 3 percentage points lower. If you just look at the data and we're trying to describe different because of the conditions or their like risk adjustment and all these other reasons. But then what we did is we put in like a fixed effect for the doctors. Explains the entire difference. The odds go right to 1. So the entire difference, our hospitalization rates in Medicare Advantage versus traditional Medicare can be explained by the fact sending patients to the doctors that have like a fixed innate kind of rate of sending patients, for taking care of their patients in a way that they'll lower returns to the hospital for avoidable, not even returns to the hospital, just hospitalizations for avoidable conditions. That seems like a good thing, right? And what we find is we rank the docs into 10 bins based on the highest performing ones to the lowest performing ones. And this bar represents the probability their patient pool contains people in Medicare Advantage. So basically, Medicare Advantage has ways to steer their beneficiaries towards the doctors, towards the primary care doctors that are at the highest probability of avoiding rehospitalizations. And the lowest performing docs have a huge lower probability of getting a visit by Medicare Advantage. So something that clever that Medicare Advantage is doing to steer docs, steer their beneficiaries towards a better performing model.
And I think you said this, but you're defining performance as rate of referring to certain procedures.
That's performance by the probability, by looking at their panel of patients and saying what's the rate at which their panel of patients have a hospitalization for an avoidable condition. So we looked at, so that's the basic story of this, but we're looking at and then like, how did they do it? They mostly do it through their HMOs, not their PBOs. So it's like through the management of care. Some carriers do a better job than others. Some insurers like Humana, all our carriers, United doesn't do as well at this. What we're doing now is could be that they just like doctors that do less. Not just for like good reasons, but maybe they don't send anybody to do anything. What we're looking at now. It turns out that's kind of true. So it's unclear if our measure of quality is really a measure of quality or really just a measure of being less into medical care. Also be an attractive type of doctor for a health plan that makes profits by making sure that the people in their plan just care.
That's what I was wondering, and Karen, I think, was kind of getting at the same thing, like how you describe performance. But then you said it's avoidable hospitalization.
Yeah, so we're only looking at.
Is that a good thing or a bad thing, or don't we know?
We want to, so that were the conditions that we excluded. We only included patients in these panels that had either diabetes, asthma, hypertension. Among those that manage these conditions well, hospitalizations that they get might be related to poorly managing those conditions. It's a very common measure in health services research for measuring the quality of primary care.
What about the health of those beneficiaries? Is their health really better?
The only data we have, the data we're using here are the national claims data. So we have the advantage of having everyone in Medicare Advantage to be able to have a big enough patient panel, the majority of primary care. It's a national study. The disadvantage is that like we're not looking deep enough into any single panel to know like some like innate measure of their health. We're just using what the claims data tell us. So that what you're pointing out is definitely a weakness, is that if two people that have COPD. One might have like on their chart, like this is a really bad COPD, and the other one is like, it's not so bad. We treat them the same. Definitely unmeasured confounders here that could be related to these results. I really geek out on this stuff. Ghost physicians. So there's a big thing in my little world. You might not find this as interesting and as fun as I do, but health plans are being held accountable for the fact that they have these provider directories that have just like bad addresses, bad phone numbers. These people, you finally reach them, you find their right phone number, and they say, I don't accept that plan, but you just got the name from their list. So how do you hold health plans accountable for the fact that like everyone has crappy lists? Turns out that if you ask people at Johns Hopkins plan or at Johns Hopkins health system to list all their doctors, all their addresses and all their phone numbers, they would get it equally wrong. And, the health plans are the ones that are, kind of the doorway into making sure you can see a provider that would be the right provider to make sure you get all the benefits that your health plan has. So like they're contractually obligated to give you this correct information, even if you go to it's a systemic complex issue. But from the perspective of the health plan, the problem is that they may be overstating the type of access you can get. We should hold them accountable for that. So that overstatement is, the term that's used by policymakers is that they're putting in ghost providers, is the word that they use, which are providers that appear to be in the network, but they just aren't. They're phantoms. They could happen for a lot of reasons, just like bad data. They're just like they're just like basically the doctor doesn't exist. Yes.
I can understand why this problem originated. I'm a little iffy on why it's still a problem today. It seems like a problem that should be solved.
Yeah, well, just last week, CMS has now CMS now has a directory of every doctor, at least it publicly for the first time. So I've been trying to solve this for 20 years. That doesn't get solved because there is no right answer. If you get the perfect answer today, you find out exactly where every provider is and they get the right phone number and address at the perfect point in time today, it'll be different tomorrow. And the first person to find out about it would be maybe the doctor who shows up at a new office. If the doctor showing up at a new office, the contract between the payer and the payer and the provider, that's a contract. Like for Hopkins Health System, I don't know who negotiates. If there's somebody in the health system sits there and the C-suite or whatever and negotiates that contract. That's one person in this. And how many? What's that?
Dave Friel,
Dave Friel, yes. So what are there? About 20,000 employees, 30,000 employees in the health system. So you know where everyone is at every point in time, right? That's the source of the information for the health plan. It's just always a moving target. And some of the most important information also changes day to day. It's is that doctor accepting patients at this point in time? And also that thing of accepting the patient at this point in time could vary by the health plan. Be accepting your commercial patients, but not but yes, you think in this AI day and age, and there's a lot of companies that are trying to solve this problem. But then there's credentialing. Anyway, haven't been solved yet. There's a lot of private companies trying to be a solution for this. Even Google was for a time trying to do it with searches, things like that. But it's a problem that needs to be solved for a lot of kind of deeper reasons about holding plans accountable, making sure that as a consumer, you're purchasing a plan that's valued. So we've tried to address this issue in a predictive way to try to identify the health plans that are doing this in a way that seems like they're just trying to game the system. The idea is that my network is doing things differently than every provider directory looks bad, trying to game it in a way that doesn't make sense. I'm not going to go through all the details here. this is a huge problem. So, 61% of providers in a network are actually accessed by the health plan. That's not even like less than 2/3. Maybe are accessible, but like no one knocked on their door this year. Maybe they're far away or the plan is small and there's a lot of doctors to choose from. And then there are two types of ghosts. One is like, they're just doctors listed on plans that like would never see a patient in Medicare at all. And then there's what we call network specific ghosts. They're seeing patients from other health plans, traditional Medicare, but they're not seeing anyone from mine. We're trying to, be more rigorous about how we define this problem. Policymakers just, kind of equate a bad phone number with a doctor that, you knock on their door and say, yes, I'm listed there, but I would never see you. I think those are kind of different degrees of the problem. So trade-offs of managed care, we have these networks, we'd like them to deliver high value. And we see some estimates that there might be high value. They're steering patients to primary care docs that manage care in a way that is less likely to have an avoidable rehospitalization. But there are lots of problems with, making that work for patients. They don't really trust the system. They have these lists. They can't find the doctors. So there's a huge trade-off of managed care, and just the complexity, being able to access care creates a lot of distrust in the system, including these directories. We're trying to make that work better. There are potentially some advantages. How are we doing on time? A couple more, but forgive me if I'm going too slow. Market dynamics. So this is I think a little more into the economic-y stuff. So what's happened, and this is true, I think, not just for Medicare Advantage, but value-based care more broadly. If you're a provider and, like the traditional doc, as the bag goes to the, it's an office, maybe, one person at the front, and it's just like a small office, single primary care doc that sees patients, it's a small office, but that pretty much doesn't exist anymore. Most doctors are an employee of a health system. It used to be that way. It used to be most docs own their own group and they're on their own. It's changed dramatically in the last 20 years. Many also are have their own groups, but the groups have gotten huge. Part of the reason for that is value-based care. And these value-based payment contracts, data is so important. You need a huge infrastructure to make this stuff work. Medicare Advantage wants to work with doctors that have that infrastructure that can use data to drive value. So as a consequence of both Medicare Advantage and other value-based payment mechanisms that exist in traditional Medicare, huge consolidation of the provider market. Like, instead of having onesie-twosies, you just have these huge organizations delivering care. And on top of that, to drive care coordination with a plan, easier to coordinate if you're a health plan, if those doctors work for you. United Healthcare has 90,000 doctors working for United Healthcare. It's called like vertical consolidation, vertical integration versus consolidation. So like what is the impact of these two different versions? Consolidation, is it good for patients? So we're going to break it down a little bit between integrated Medicare Advantage contracts. So like that's like what we have at Hopkins. Hopkins has its own health plan and they can kind of coordinate care. It's like a hospital-owned health plan, plan-owned provider organization that's United having 90,000 docs. There's other vertical alignments like risk-based contracting where it's more informal arrangements. No matter how you define these arrangements, basically, I'm not going to get in. This is time. This is like the number of there's a number of providers that are part of. Enrollment's going up, and basically the health plans that have lots of docs connected to them is going up. So if you're buying a health plan and Medicare Advantage, you're most likely part of a health plan that owns a lot of doctors. This is being done by all. Now, you don't see it so much in traditional Medicare. You see it a lot, that behavior in Medicare Advantage plans. Now you're part of these health plans, own their own doctors. So is this associated improvements in outcomes? What we find is the hospital is integrated with the coordination between the hospitals and the doctors. You find some benefits. But the plan is leading the integration, so it's the United owning 90,000 docs. You don't. It shows that patients get like mysteriously sicker to this risk coding. Use these health systems they use systems to work with doctors to make sure they code up all the problems with the patient so they can get higher payments, but we really don't see improvements. And so it's it's independent of like what might be happening on the cost structure side and prices, patient outcomes perspective, and contracting with providers, take advantage of some of the incentives of Medicare Advantage has not been good for patients. That's kind of summarizing stand there, right? So if it's a health system, an integrated plan, we sometimes see some benefits. So on the plan side, I want to kind of what's happening on the patient side. I'm going to talk about here benefits. So many people are familiar with supplemental benefits. So some people are. Thank you. There's always been for many years, it's been supplemental benefits like dental and vision. 5 or 6 years ago, they added like food benefits to get home care. You wouldn't be able to pay for in traditional Medicare. Transportation benefits, housing quality benefits, all through your Medicare Advantage plan. Also hear about gym membership. We just heard the other day that there's a plan in Puerto Rico, you food benefits to go to Kentucky Fried Chicken. So why would they do that? And it really it can be a marketing. Maybe this is a great way to think about modern healthcare. We want more of this stuff going on. Are we incentivizing it appropriately to get positive outcomes? That's something we looked in a paper that's forthcoming at Health Services Research. I'm just going to show you very quickly what the main result is. Didn't find any differences in like the ED. Didn't find any differences in like just like rehospitalizations or hospitalizations or rehospitalizations. This is whether the health plan offers the benefits to their beneficiary. The data don't yet exist for us to identify which beneficiaries got which benefits. We're looking at like the treatment on the treated. We're looking at where all the health plan offers this plan, maybe offers these benefits, maybe like 5% get it. We don't even have it. So this is really the first look at outcomes. We don't really find differences in outcomes. We looked at a lot of subgroups. So for the non-dual frail elderly, we do see some effects. So those that are most vulnerable because of frailty, like maybe the home benefits, food benefits, housing safety, we are starting to see some impact on reducing rehospitalizations. It was kind of like an ex post analysis. So you get like a non-result, you keep digging. But the basic story of this paper is see any effect, but it was better data. We'll get to the bottom of it. Before I end this little talk on Medicare Advantage, happened in the past 2 years. paper we published in JAMA a couple months ago, it turns out that there's a recognition that the government's been too generous. Health plan. It started to peel back some of the ways that money is flowing to the health plan. What the health plans are doing are, well, if I'm not going to make money in this market or that market or in this entire Medicare Advantage market, I'm going to drop out. I'm accountable. My, shareholders and making money, I'm not going to participate. Turns out that on a typical year, over the growth of Medicare Advantage, maybe about 1% of benefits. So like, say your mother, your grandmother is in Medicare Advantage, and then they get a letter that says, oh, you're the health plan you're in now is disappearing. So either select a new plan or go back to traditional Medicare. I have these doctors, I know what I'm doing. I got to find a whole new plan. That kind of forced disenrollment was very uncommon. This year, so January 2026, 10% of beneficiaries, poof, they lost their plan. They're like, oh no, I got to find a new plan. It turns out that like the plans for duals are more profitable, are still profitable. So the non-SNP plan, so most people give a proposal going in next month. It's going to see if this disruption has caused changes in outcomes. Imagine if you need continuity of care, this type of disruption can be really tough. Also, in some states, the one getting all the news is here is Vermont. There's almost no choice. If you want to stay in Medicare Advantage, which could be important if you just don't have any way to pay for your dental vision and you have like out-of-pocket max and no other supplemental insurance, you almost have no other choices. You have to go back to traditional Medicare. And plan for that type of disruption, it could cause some pretty serious ability to kind of maintain action with your.
Is there a particular reason? Are those states in particular being targeted, or is that just random? Like, it surprises me that stroke belt states are not targeted, because wouldn't there be more unhealthy people?
Well, I mean, there's a lot to do with the really hard to run a managed care plan in a state that's really rural, or a state that has like hospitals that are going under or something like that. Contracting in the kind of the more densely populated areas. Lots of lack of density here, and then there's just the hospital systems in Vermont have been going under. So it's like no contract. It's just really So anyway, it's just like specific market effects that make it really hard to be profitable running a managed care plan.
Why Maryland?
Oh, so here's the deal with Maryland.
We're special.
So anyway, Maryland has almost zero managed care, Medicare Advantage. It's the lowest Medicare Advantage of any state in the country. It has a lot to do with the rate setting here for like 30 or 40 years, where the rates for commercial plans are the same as Medicare. So Medicare pays higher rates on traditional Medicare. So you just want to be in traditional, it's hard to make money if you're a Medicare Advantage. In this state, so of course, we're so good at making money at Hopkins. We have a Medicare Advantage, like one of the few that doesn't do very well. So that's my summary here of implications for MA. Still learning about it. So over half of the elderly are in these health plans, these private health plans that do lots of funny stuff. It changes every year. We didn't even talk about prior authorization. Seems to be what everyone wants to talk about. There's so much we have to learn about what the impacts are in older Americans. It's what our group is doing a lot of. Those are what I showed you are all papers that I've published in the past 2 years. A lot of activity going around. We meet monthly. We've called the MA Data Lab. Use the Medicare claims for Medicare Advantage, which started in 2016. We have the data that sit on our servers. We call it the HARP platform, Hopkins Analytics Research Platform. If you're interested in doing administrative claims research, we have lots of data that to buy these data on your own for your own research project could be like $3 million. Or licensed to Hopkins, and if you want a use agreement, how to write, you can reuse the data for a low amount of money, and then we can, help maintain the data. Our research platform, just like HBHI, like Harvard. All the data we have. If you're curious, I could click on that link and show you all the data we have. We have the minimum data sets for our nursing homes. We have census data. Lots of data that allows us to study with older Americans. If you're interested in learning more, contact me. So that's my MA presentation. If you're interested in learning more, what I wanted to do is also tell you a little bit of this health initiative, right? Before we do, are there any questions about the presentation here on Medicare Advantage that just kind of ripped it?
I know this was a long time ago.
Oh my goodness.
I should have interrupted you then, but I was just fascinated by everything. Oh, maybe it was 18. There we go. Yeah, okay. So I was looking at the collection of market share that everybody owns. But I was thinking about the fact that it seems like politicians that are trying to go after monopolies are going after CVS, primarily Aetna and Oak Street. And they've been trying to monopolize the old people. But why are they not going after Optum?
Well, Optum is in more trouble than anybody.
Oh, really? Okay. All I see on the news is CVS, and okay. Well, so I'm just that's just because that's what the media is picking up.
Because I think there's probably they're specific. They're going after Optum too.
Okay.
Is Optum United?
Optum is United. United Health. United Health's provider side is under Optum. United Health Plan. Both sum up to United Health. Optum basically. Yeah, so it's they're it's been an audience.
Quick question. Maybe it's not quick. When somebody say writes a proposal, or when I'm reading a paper and they say that we included Medicare, but we excluded Medicare Advantage because we don't have all the data for that. How much is that? How much of a problem is that? Like, is there nothing that can be done?
In Medicare Advantage, we got the data right here. So, I guess it depends on the question. So, economists are thinking about like how health system, kind of the health system functions and the dynamics. It's probably no longer appropriate. But if you're asking more like clinical questions, I think it's still okay, except if you're following longitudinally and they drop out of your data because they entered Medicare Advantage, that's probably a reason. Or if you're looking back in time and they suddenly show up, sick because maybe they left Medicare Advantage, then that you would only observe in the Medicare Advantage side, a skewed, kind of criteria, unobserved part that is selected. I think it would depend on the question. Or acute stuff, and you're following longitudinally, it's probably less. If you want to follow people for chronic conditions over a long time, a lot of people transition in and out of Medicare Advantage. You kind of lose that continuity, and that those transitions don't happen randomly. They happen for clinical reasons. That makes sense. I think you have to think through the question and the selection that you.
I'm just wondering about the extra benefits offered by Medicare Advantage plans like vision and hearing, which are benefits that most older adults want and need. So I don't know, do you ever see traditional Medicare adding these benefits? I know there's a lot of policy discussions around it, but is there be a benefit for them to do
the right legislation?
Yeah.
Costs a lot of money. It'll never happen. You have a lot of evidence showing how good it'd be for older Americans.
Yeah.
Long-term care is probably the biggest one. Safety net for that at all. expensive too, and we start just the political. I think you come up with all the reasons why for older Americans, it'd just be really difficult to get that. My own take on it.
No, I mean, that makes sense.
Plan no longer exists, how much competition is there in the market that they can face with?
Yeah, it's such a great question. We put this map. Here is, in those states here, this is where the enrollment was, where the forces enrollment, I don't have the right map, but there's a few states where, there's no plans left. And they're more rural. You know, next study, if we get to study the areas where there's more competition versus less, but what's happened is just expanded so much and you can make so much money that Medicare Advantage was going into markets where probably there isn't much benefit. There isn't much advantage to Medicare Advantage. So they're leaving the place, it's like last in, first out. Kind of. Often that's kind of more rural markets where managed care has been less common. You know, frankly, might be better off in traditional Medicare anyway, and this making money off of it. We're going to study next. Hopefully, they'll give us a grant. They'll be able to submit it and review it. All right.
An online question from Dr. Boyd. Cynthia, you can unmute.
This was a great talk. Thank you so much. I could hear pretty well. I hope I didn't just miss this. But in the slide that you just showed about the forced disenrollment, what do you know about like what happens to those people? And do they go to other MA plans? Do they go to fee for service? Do they have difficulty buying supplemental plans? I'm not sure I'm using that term right, but like the thing through the employer that basically is the complement to the main Medicare benefit.
Supplemental.
Yeah.
That's the grant we're writing. We're submitting. Musselbeck and Frank Xu and I are submitting in June. So I know the answer to that. You know, it's a wait. You know, we'll hopefully get funded, and it's wait a couple of years. But since these exits happened in January 2026, we got to wait a couple of years for the data to really be able to evaluate what happened to these people. It's unanswered. Stay tuned. Yeah.
That's great.
Okay, so I know I want to tell you about its business of health initiative. Oh, you want to hear about it. Here we go. We retreat. This is our last retreat in the Hopkins Bloomberg Center. We have about 90 people. We have retreats twice a year. You can look really carefully. You might see yourself. It's a community that connects faculty are interested. In, you know, these questions like we're asking the Medicare Advantage. Like this is a really complex system, national level, in organizations. How organizations deal with policy, communities interact with the organizations that to manage to providers in their markets. So we're thinking a lot about technology through line between the market level, the organizational level. So we bring faculty together that sit in different schools. In this, it's a university-wide initiative. We're funded through support from the deans and the post office. It's funding model at the moment. But so we'll see. Faculty sit in public health and medicine, business school, nursing. Leadership team. The health system, you can see here medicine. Yeah, got McDonald, Jane and Jody Siegel. Medicine here. You know, where does this business of health come in? And the way I think about it is kind of vague. Like when I talk to the health, we're all in the business of health, but this is great. Talk to people, business world, they're like, I get calls from like Cato Institute or these like think free markets are what it's all about. And, oh, you're going to defend business to the end of the day. Trying to be a tent that brings people together that sit from different perspectives. So we kind of keep this idea of business and health vague. But, ultimately from a scholarly perspective, we're thinking about the role of business and incentives, advancing health or being a kind of a barrier to advancing health. In the Medicare Advantage talk, there's just so many trade-offs involved, reasons that you'd want to have business promoting innovation in this space, but a lot can go wrong once you get the incentives right. That's basically what we study. And just one example. We kind of bundle our work into these 4 pillars: market level, population level, and organizational level. We have a mission. I always hate reading these words because it's just this mission. The goal is to just advance research, but connect it to value, access, and trust in healthcare is our little line. What do we do? These, where it's a mission and bring people together. Our approach is to create platforms that community research that we do have an impact. So, do it at the scale as a kind of platforms of collaboration, scale, where people come together and kind of co-learn. Retreats, you saw from that picture, we do a work in progress seminar online every month since people are scattered across multiple cities and multiple places. A lot of our partner groups that have more local talks will just spread that information. So you get on our listserv and you hear what's going on at the business school, the nursing school, all types of talks that happen across lots of different scholarly disciplines, all related to health services, research, business and health. A number of smaller working groups, you can dig in on a single issue, meetings on AI and healthcare. 50 people meet every month on that one. Some of you are involved in our Truveta initiative, a large data source for medical records that span like 30 health systems, and we're giving out that for about a year. And I just saw the list today. We have about 7 investigators that are applying for the data that sit in the Truveta platform and the new kind of platform. So we have these user group meetings once a month, so you can learn more about it from other people who kind of master how to use it. Have Graduate Academy member here in the room. Hi, Lydia. We bring students who are involved in master's programs throughout different schools together, master's programs, kind of learn about what other people are doing and thinking about problems in the business of health, like Health Vantage Point, their fellowship in school of medicine, sitting in a business school, getting in a wonderful program. Thumbs up. We give out pilot grants and reward program on our data analytics research platform. We probably have over 100 people on that server. This is a Bloomberg Distinguished Professor cluster we've been hiring. And then a lot of what we've been doing lately is a lot of external convenings. We have a monthly conversation on the business of health, like a webinar series where we talk about up and coming issues with like newsmakers and stuff like that. It's an awesome series. We have one coming up on organ transplantation. And we have convenings in Washington, D.C. So we had a Nexus Award, and just on Thursday, I ran a convening on Medicare Advantage. We had Dr. Oz come talk. Like all the people who basically run Medicare Advantage from CMS and legislator, all the kind of former type of people who now work in policy organizations throughout the government. We had payers there and providers, and it was a great day. Great day. And Lydia, thanks for your help. Wasn't it a great day? It was really interesting. It was awesome. The pictures from Dr. Oz was nuts. Anyway, let's get a picture. For what it's worth. So anyway, it's all about connecting. And so here's a picture of the ad we have, and we all connect. We'll have another one in September, and is interested in kind of figuring out if this is a community they want to participate in, and more than welcome to be in the community. Some of the vibing we do here at our Graduate Academy, students together to be part of the talks we have in Washington. We had Sarah talk about supply chain of for friendly supply chains in healthcare. Mark Cuban, very interesting. That's online. It's worth watching. Come chat with us, and like us, we'll have a picture of this.
I have a question about that. So it seems really interesting that you have this presence in Washington. You present this data that shows Care Advantage is maybe not the best financial choice for the government to make. So like, what's their reaction to data like that?
So I have an advisory my initiative, and my friends are in like and to know that I've invited in leaders in the healthcare space, in the private sector, and private equity. A whole other type of research is totally trash private equity. So now, like at the dinner, I have my advisory council in, and they're like asking me what I think about private equity. I said, have you read my papers? And they're all like, yes. But like it's a chance to really get outside of the, I'm saying this is what the averages tell us in the data. And then they're telling me how private equity works and what the good firms are doing, and that they know there are bad actors. So I'm like, how can we work together to make this system better? Because it's not like we're going to write the perfect regulation. Some state might make some of this stuff illegal and others won't, but unless everyone's at the table. So the thing about our event that we had last week, we wanted the payers, the providers, and the policy people and the academics to all sit on equal ground. The data are presented, everyone's talking about their perspective, but most meetings in Washington, it's the policymakers talking to the policymakers, the payers talking to the payers. We're trying to create a bridge for people, like we're just having conversations about these things can go forward, like creating connection that wouldn't exist otherwise. That's our.
I guess, well, but like, do members of Congress or people, you said senators come and talk to you, like, do they see this data and think we have to enact change to make Medicare better? Or not?
We spent the morning talking about how bad prior authorization is in Medicare Advantage and how like we need some fixes for that.
Yeah.
And then Dr. Roz comes for the keynote and says, there's no prior authorization problem in Medicare Advantage. We talk about how all the data, we had all the people from like MedPAC there, all the academics, were pretty much in agreement that Medicare Advantage pays like 25% more per dollar, basic traditional Medicare person. Roz comes in and says, we did our own study and it's 2% higher. At the end of our administration, our people will do another study and our goal is to get it to zero. And I promise you we'll get it to zero. I'm sure he'll get it to zero with his own researchers, right? So there's so many competing interests, and and I think this is one of the problems with changing healthcare from a kind of a national scale. I mean, it's a $5 trillion industry, and so what's kind of bending the cost curve for many of us that would benefit from that? Those are real jobs. People would lose. So that's what happens in Washington. Things don't really move. How much you show in the data, that there's so much consensus that some of these things have to change. So the big thing that did change was this risk adjustment. It's like V24 to V28 on that thing. V28, if you're in a Medicare room with Medicare people, Medicare Advantage people, say, what do you think about V28? Well, that person will bore you to death for the next 2 hours. Basically, they tried to address risk adjustment, and then a lot of these managed care companies started losing money, and that's why they backed out. And that's why 12% beneficiaries lost their plans. So you move one thing in the system, and then 12% of people get thrown off their plans, and maybe they can't find care. So it's an interconnected system that's very, what might be good to change in one part of the system has implications in other parts. It's really sticky to make changes, even if we agree. But we talk about it. We don't really do anything about it. That's the sad. I overstate that. I think you can make changes on the margin that move in the right direction. That's pretty much what I'd say. You should check out our conversations on the business of health series. That let me know. And this is kind of my last slide. I'll show you. So, I want to incubate ideas and research. So, like, for example, we had a retreat years ago. We have these breakouts. What's the most important thing to think about next in healthcare? And these groups say, we should be studying trust in the healthcare system. Now we have this annual survey. It's bigger than the Gallup survey. It's the trust people have in different segments of that. Do you trust the FDA? Do you trust CDC? Do you trust doctors, nurses, health plans? Measured that. We started before that murder of United Healthcare Objective executive was like the front page news, and the whole idea of trust front and center. But we have before and after that, and now trust is a big deal. The CDC and FDA. So we're really pushing on trust, but it really helped that we started these conversations and incubated some of these ideas before it became national news. It keeps us kind of a little bit ahead of the game by moving outside of our daily research groups that we have in our local environments to meet with people throughout the university or thinking about things differently. What do we really need to do to not just change the health system incrementally, but so in different ways we've been able to kind of push forward faster. We've really universities have been unable to do because we connect people across teams. And I will. Any other questions about this? For me. Mr. Everett.
Other questions? Anyone, Lacey?
I guess for your talk, I was a little bit confused about sort of how when a person is pulled off of one of these Medicare Advantage forms, what's the relative that causes that? Is it what's the relative frequency of or that's because the company itself has pulled out of the market versus they're making decisions about individuals that need to be.
So it's not individuals. They either plan will either, so plans choose which counties they want to sell their health plan in. So an exit could happen because the health plan says, I'm going to stay in business as a health plan, but exclude these 30 counties. So they don't remove people, they remove counties. Other health plans will just disappear entirely. You'll see something. This health plan is no longer participating in Medicare Advantage. They just wiped out all their health plans, the entire segment. So those are the only two ways that measuring disenrollment get kicked out as a person.
There's no mechanism.
There's no mechanism to say it you're a bad beneficiary and you're gone.
There swap out the health insurance plans at Hopkins periodically.
So yeah, that made news, right? Where that's a little bit different. Where Hopkins left the network of United. Yeah. So you'd still, if you were a beneficiary, you'd still own United. Let's say you wanted to go to Hopkins, then you're kind of you're.
Fair enough for those bad beneficiaries, they can decide to pull away, right?
Beneficiaries
And it's a benefit.
year, they can go back in the market and pick a different plan. They can go back to traditional Medicare. They can move around. Just, but if you're connected to a certain set of providers and you have a complex set of conditions, a little sticky, right? Your health plan actually can change the care you receive. But if you're relatively healthy, it can be a pretty costless type of decision. And it offers lower premiums. Sharing, you get a vision benefit or something. That type of shopping happens all.
I know my doctor had his own practice for many, many years. And at one point we received a letter saying, I'm going concierge because I can afford to provide the care with the reimbursement that we're receiving. And I wish I had stayed with him now. He was a great doctor, but I mean, we just thought at the time that the fee wasn't, you know, like $1,500 a year to stay.
Care is really in crisis. Exiting. I've got a paper on that in health fair. Rate of incidence and doctors that are going in. Also find that now corporations are buying this concierge health plan. Even concierge medicine is getting we're real optimistic talk. Be healthy, take care of yourselves, eat a good dinner. And or hopefully you'll enter the age where you need Medicare Advantage.
That's what they say.
Oh, yeah, when my mother-in-law, like,
Don't tell them the secret.
we went to, like, I guess her, finally retired in his 80s or whatever, and they had to buy Medicare Advantage. They had to buy out, I went to Medicare in their 80s. I don't know, I was so pissed at me. It costs so much. Like, how can you do this? But that's a whole other. Thank you very much, everybody.
Thank you.
Thank you very much. Interesting.